I don't know enough to be able to speak exactly on how ozone would be affecting you, but as far as nitric oxide goes, we know it's good. We know it helps with blood pressure and stuff like that, but whenever it keeps producing more and more nitric oxide and you don't have enough antioxidants to bind to it and take it up and use it the way it needs to be used in the body, you start having a really serious problem.
I don't use this for the close your eyes and you wake up and you're done with the kind of SRP case. You know, this is for those really tough cases, aggressive perio, juveniles, whatnot, where I need to try and just kill that bacteria at all costs.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists. This is your student-focused roundtable for the month, brought to you in part by Q Optics and Elevate Oral Care. I just wanted to give a quick plug for Q Optics. Yes, they are sponsoring the show, but I also want to let you know how easy it was to work with them. We met with them in Chicago at one of the big conferences called Chicago Midwinter. And right there on the exhibit hall floor, they walked me through all of the necessary steps to be able to get really dialed in for a good pair of loops. Now, I've always been skeptical of loops, and my experience with Q Optics really changed my point of view on loops. So if you're thinking about it and you have the ability in the program that you're in to have Q Optics come in, make sure you guys reach out. You won't be sorry.
And I very much enjoy Elevate Oral Care because they have one of the products that I use pretty frequently, and that's silverdiamine fluoride. And if you're just now hearing about silverdiamine fluoride or you wanted to know more about it, you can actually go to their website and check out some of their webinars and information. They also have a ton of information on motivational interviewing, and you and I talk about that quite a lot on this podcast. I'm a huge fan. I've been practicing motivation, and it is a true practice. I've been practicing motivational interviewing for a while. So you can head over to their website, elevateoralcare.com, and learn more about them. But let's get into the Student Focus Roundtable. So at the beginning of the Student Focus series, this was your brainchild last year in 2019. Isn't that the year? God, they're flying by.
It's the beginning of 2019. We're like, look, the students need a little bit more direction. We really value that. Like, we're so impressed you guys are even listening to this. Let's be honest.
So true. Yes.
So, let's give them something. They're taking the time to listen to us. Let's give them something that they actually could use.
And you came up with the idea of a roundtable, and we brought on different people that would talk about one particular topic. And then I kind of hijacked it for 2020 and made it a little more researchy because that's what I do. But I hope that you guys find it helpful because what we're aiming to do is bring on people who understand the topic and let them explain to you how they're looking at research and applying it clinically. Because what happens is we graduate with the knowledge we graduate with, and it might be a little I don't want to say up to date. It might not be as up to date because they had to get you graduated, right? But there's stuff on like HPV that, it's ever changing. And so we got to stay on top of that. And so we're going to bring the experts on so that we can teach you how to read the research and apply it to your patient care. So you can always be doing that up-to-date evidence-based clinical practice that we talk about so much. And we hope you enjoyed this student-focused episode.
Hey, Michelle.
Yeah.
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine.
So welcome everyone to the student-focused roundtable. Usually we have 3 people on this topic, but I'm still super happy with the 2 that we have on because they're brilliant. And this is a topic that they love. And we're going to talk about subgingival irrigation. This is kind of a hot topic, not just for the student-focused roundtable, but also in dentistry. I mean, I feel like the pendulum swing is quite wide on this and large because either you do it and you're charging for it, or you're doing it and you're not charging for it, or you just don't see the value in it at all, which is kind of where I land in this right now. And I just wanted to, before I introduce my guest, to explain to you guys, well, actually me introduce you guys, and then we can have a discussion around this article. So welcome Spring Hatfield and Daniel Jeremy Lopez, depending on how you know him.
Daniel's the business name. It's a professional name.
Daniel, I love it. So welcome back to the podcast.
Thank you.
Thanks for having us.
So if this is a one-off for some people, just give a little bio about, I'll let Spring go first.
I hate doing this. You know this, right?
I know. She's brilliant, y'all. Just so you know.
I'm just a regular hygienist. I went to hygiene school and I've been doing hygiene and working in dentistry for a long time, like 20 plus years. So that's my bio. And I'm sticking to it.
And I'm going to add there that this just a hygienist also takes epidemiology and immunology classes for funsies. So she's anything but your average RDH. And same thing for Daniel. Welcome, Daniel.
Thank you. I am also a regular hygienist. I graduated in 2012, so I've been at it for about 8 years now. And the majority, or actually the entirety of my career has been working in public health and specifically on HIV/AIDS positive patients in the LGBTQT community and the underserved community of the entire New York region. And for fun, I like to go with Michelle on mission trips. And
yes.
It's something we're very passionate about. And I'm also kind of a geek when it comes to finding out little intricacies and whatnot and little hidden things and gems about dentistry here and there and trying to apply them as much as I can to help my patients because I like to just throw the whole kitchen sink at people.
Yeah, you're really great at practical tips because, again, in public health, we have to serve a population that might not have the ability to get all the little things or do all the recommendations. There's a lot of barriers. And so you're really great at the practical tips. And I'd also say because you work in a practice that has medical, you really see the real oral systemic side of care.
Yeah, we do a lot of collaboration with the physicians, nurse practitioners, and PAs and whatnot, and it's a really unique collaborative, actual whole care environment that you kind of only read about. I love just walking 2 doors down and finding my patient's doctor and just you know what, I see this, come check it out, and boom, that's it.
It's so nice. And you're wearing our Mission Trip One World Health shirt. I see there. I know you guys, the audience. See that, but he's wearing our One World Health volunteer shirt, which we also get to experience that same scenario on the trips where I can just walk over and be like, I'm seeing a ton of acid erosion. Can we talk about maybe some other issues that they might be encountering? And they're like, oh yeah, I didn't even know that. I can't believe you guys saw that. And we're like, oh yeah, this is what we do, y'all.
Yeah, that's a big one we usually find.
Yeah. So to get into this topic, in my whole career, like you said, you started out in the public health sector. I've moved there, but originally I've always worked in perio. And that was where I spent a strong, 12 to 13 years in perio implant driven practices. And I occasionally did subgingival irrigation. I didn't do it often and we didn't charge out for it. But like I was mentioning that some offices are doing that and they're charging out per site or even charging for the bottle, using a little bit and then sending it home with the patient. I've heard that. And I took that same philosophy of doing subgingival irrigation to the clinic where I was teaching. So teaching the dental hygiene students. And there was this systematic review that came out in 2017 that I read, and it was in the Periodontology 2000 journal, and it was titled Patient Self-Care of Periodontal Pocket Infections. And granted, this is saying it's periodontal, or self-care. So things that they're doing at home. And it went through a lot of different things that they could be doing. It even went through chlorhexidine as the gold standard, which I can read that if we want to get into it. But one of the things that it mentioned is it really it's not necessary in a lot of ways. And then I discovered airflow or subgingival biofilm management with erythritol or glycine powder. And that really changed a lot of things for me. And I didn't really charge out or didn't even ask the school to even get more chlorhexidine to do this subgingival irrigation. And Not everyone is on that path though. So I would love to hear your points of view and also the article that you brought and break it down for all of us, why that's relevant and how that changed your practice as a clinician.
So I personally don't do subgingival irrigation any longer either. I did do it for a while, but like you, I read a bunch of research articles that were saying that it really wasn't effective. So I chose an article that actually brings in something that I was interested in learning more about anyway, because I hear a lot about, and that's the ozone infused waters and oils and things like that.
Ooh, I am very excited for this.
Yeah. So I really am going to be completely honest and tell you that I don't know that much about it prior to what I'm reading now. I've read a little bit on it, but I don't really have a whole lot of understanding. So I had to, after I read this article and read what was in it, I kind of looked a little deeper into it. So I'll kind of give you a little bit about what I read outside of this too. But this basically, it took 25 patients that had generalized moderate to severe chronic periodontitis, and they did a split mouth random study type thing where they irrigated half the mouth with chlorhexidine and half with ozone olive oil. So basically, they've been using ozone for years for antimicrobial things in medicine and cleaning and stuff like that. And they state how it affects the immune system. It helps with immune modulation and stuff like that. And they compare it to the chlorhexidine. And essentially, they came up with the fact that there's absolutely no difference in the results between the ozone or the chlorhexidine. And they go on to cite some other studies that also used ozone, and they used distilled water as an irrigant, subgingival irrigant for periodontal disease, and got the same results. So though they say you can use it just the same way you use chlorhexidine, there's no real evidence that it's making a huge difference as far as this study goes. Now, what I did after this is I know that ozone isn't just safe, like straight across the board. We know that it causes other issues and stuff when it comes to immune system response and stuff like that. So I looked into it, and it falls into the category of the Goldilocks principle, which means basically not enough is bad, too much is bad, but if you get just the right amount, it's really beneficial, kind of like fluoride too. So you're not going to get enough to be harmful by using it as a subgingival irrigant if you want to do it and you believe in it or whatever. But there's no evidence to say that it's going to be any better than just rinsing with water. So, irrigating with just distilled water subgingivally.
I'm interested. I wonder if it's also like it's the clinician's hand that it's in, right? Because even like lasers, sometimes you get very mixed data, and if the clinician doesn't really know, like that Goldilocks, if it's turned up too high, if it's not high enough, then you don't get the results that you need. I wonder if that's the issue.
And it could be, because they do mention about how it's hard to get the right amount of ozone into like water. So they used the oil instead, and it was supposed to be more effective. But you have to wonder if they're actually getting that right, since it's got a hormetic, role. Are they getting the right amount? Are they not getting enough? Are they getting too much to cause more damage? Where are you in that? It's really hard to titrate that, I think, to be perfect in your dosing. But that's similar with chlorhexidine too, because whenever you consider the curvicular fluid and all that kind of stuff, then you're diluting it, and it's not as effective as well with that. So, I mean, that may be the same issue you're looking at with the ozone. I'm not sure.
And I wonder also about how well you place it. Do people put it in a cannular tip when they go all the way down to the base of the sulcus, or are they just kind of like rolling midway through that pocket? I don't know. Yeah,
because they definitely did not talk about technique or how they applied it in this study. Particularly, it was kind of like a baseline study. They called for more studies to look into it, but it doesn't say that, and that surely has to play a part in the effectiveness of it, I would think, for sure.
Daniel, any thoughts?
No. Like I pretty much have all the same thoughts on ozone. Like, it seems like it has good potential, but there's a high variance in one technique, how you apply it, who applies it, and whatnot. It's not very user friendly.
Not at all.
And as far as I understand, it might also be expensive for me,
Yes.
which is a big turnoff for me.
Well, let me say, they didn't mention price in this particular study I read, but I've read them in the past that discusses how it's kind of expensive and it doesn't have a long shelf life. Like
Right.
once it's mixed, it doesn't have a long shelf
Yeah.
life. So yeah, that could
Kind
be
of
a
like
problem.
peroxide, though,
Yes,
right? Like if
right.
you dilute it, you have to use it relatively quickly. And
Bleach.
Dr. Tom Larkin, he's really big, and Dr. Mike Zubiak, they're big in ozone. But again, like they've done a ton of research. They've looked into all the different ways to do it and how to apply it. And I feel like if you're there, you probably are getting pretty decent results. But we also can't talk about periodontal pockets without really thinking about the other variables that go along, and that's the host response. And,
Right.
if they have any other variables that are an issue, because unfortunately treating perio is not just like, I remove calculus, I put thing there, it heals and we're done. Like
Yeah.
there's so much more to it.
There really is, because when you mention host response, because you have to understand that ozone is it's a free radical. So it's not like it's like nitric oxide is a free radical, and not enough is bad. The right amount's good. Too much is bad. So it's not just something that you can just straight across the board go, oh, we're just going to apply this and it's no big deal. I mean, it takes some understanding and probably some training to actually get it at the right dose to be effective. I would think that anyway.
So could you explain for the audience the idea of a free radical and why that is a concern?
Yeah, I can. Let me see if I can say this in a way that's easy to understand. So free radicals are good. They're not all bad. They promote inflammation, and we want inflammation because that is going to stimulate the immune system to do what it's supposed to do. So when you think about, for instance, I'll talk about basically macrophages and periodontal disease. So whenever you have an immune response, it's going to release macrophages that are going to basically engulf these bacteria. But to kill the bacteria, it's going to release a burst of, in this case, nitric oxide, and it kills everything around it. But when it kills everything around it, it doesn't just kill the microbe, it kills all the tissue around it and everything else.
Right.
So we don't want that to keep going on for an extended period of time, because you're going to see tissue destruction from that. But we want it to happen, because if you only have, say you have a localized infection and in your gum tissue, and that reaction is what's going to help heal that. But when it goes on for too long and produces too much, that's where the problem is. And the only way, it has to do with a little chemistry too, with the negative charges and things like that with the molecules, because they have to bind to the right cells and things like that to be able to be taken up. So the antioxidants are very important. You hear a lot about antioxidants and how, you need to eat the right foods and stuff like that. So it kind of goes back to when you have a patient that is periodontally involved, what is their diet? Do they have enough antioxidants to take up these free radicals that we're introducing to them by using ozone? See, that was my question, and I don't have an answer. Let me just say that I don't have an answer, because you can get antioxidants from other places in your immune system as well, but you have to replenish that constantly. So I don't know enough to be able to speak exactly on how ozone would be affecting you. But as far as nitric oxide goes, we know it's good. We know it helps with blood pressure and stuff like that. But whenever it keeps producing more and more nitric oxide and you don't have enough antioxidants to bind to it and take it up and use it the way it needs to be used in the body, you start having a really serious problem. So does that make sense? Did that make sense?
Yeah.
Yep.
Okay. I put you on the spot for that. So thank you for breaking it down.
I was just trying to make it simple, not go too deep and make it too confusing, because it gets really complicated.
It does. It gets,
Yeah.
Yeah, it does. It gets a little convoluted, and I have a hard time sometimes when it gets that crazy.
Yeah, it gets
So
a little
Daniel,
crazy.
Yes.
what you got for us?
So I got an article, a more recent article, because on subgingival application of povidone iodine. Povidone has a pretty long history of usage in perio. One of the directors at the AIDS Education Training Center is a periodontist who's been working for about 40-something years now. And he was surprised when I asked him about, using iodine. He's like, "Oh, wow, that's old school. Even I forgot about using that." And every now and then you'll see an article pop up about it saying it's effective, blah, 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 but it never seems to get much traction. As far as using irrigants in general, like I said, I like to throw the kitchen sink at people. My particular population is more at risk for perio disease, either getting it or failing to treat it. So I try to find things that, one, don't cost very much, two, are easy to use, and three, have some amount of research supporting it. Because if I'm trying to save him, I'm trying to save these little millimeters, and why not? If it's not harmful and it takes me pretty much no effort to really do it, why not do it? It's not harming them, it's not harming me or their pockets, and it takes almost no extra time out of my appointment, because I usually will irrigate with this while I'm talking to them about OHI or their next visit or something like that. So I kind of just work it in. The article I have today is a more recent one that I've seen. It's actually from the Indian Journal of Dental Research, which is one of the more interesting publications I found. They will research anything, like anything you can think of, you've heard of, they probably researched it. And they're really passionate about dental research in India. So I actually really appreciated that they had this more recent article, because I usually see an article on iodine about every 3 or so years, and this one's from 2017, so that's pretty nice. Now, they basically did a split mouth, double-blind study on the maxillary and mandibular arches. On the maxillary arch was just SRP alone, and it looks like they chose 60 patients, all with moderate to severe chronic periodontitis. And so yeah, they split up into 60 people, did baseline SRP without any adjuncts on the maxilla. Mandibular, they irrigated with iodine, and then they followed up. They measured plaque index, gingival index, bleeding index, probing depths, everything, and then did it again in 3 months. Also doing culture testing for aggregatobacter, actinobacter mycocomitans, and P. gingivalis. Because as we know, those are two of the biggest instigators and inflammatory exacerbators of periodontitis. That I'm less interested in, whatever. But they do have really nice results. Let's see, as far as clinical attachment loss, probing depths of the maxilla compared to the mandible was an average of 2.61 following 3 months of full mouth SRP with mechanical debridement alone. And those probing depths were about 2.61 millimeters. And on the mandibular arch, which we know is the one that's usually a little more impacted as far as probing depths go, an average of 1.58 millimeter probing depths. So that was a pretty nice result there with the iodine irrigation. They have very significant results as far as the bacteria cultures go with reducing AA and PG. And I mean, that's pretty much it. It's very, very straightforward. It looks like they have like lots of nice pictures here that I'd like people to see, if you care to share this somehow.
Well, tell us the article name,
yes,
and where they got it, or where you got it, and they can go take a look at that.
I just did a Google search until I found something that was actually open. The Indian Journal of Dental Research. And the article is called "The Efficacy of Subgingival Irrigation with 10% Povidone Iodine as an Adjunct to Scaling and Root Planing, a Clinical and Microbiological Study," from 2017.
Yeah, so do you mentioned yours was from India? Mine is too. I just had to double check, but it is too.
I love all of the research that comes from the Indian journals.
Yeah, it's great. And I want to mention that for a second, because throughout my career, I found very nice articles and very nice studies done from various countries, but especially the Indian dental journals, because they're very proactive about this kind of thing. And sometimes I'm met with a little backlash because people don't.
Because it's not from the U.S.
It's not from the U.S. and we're the best, America.
I hate to tell y'all, but the U.S. is way behind on dental research.
That's what it seems like. That's what it really seems like when you look at these journals from other countries. Mm-hmm. So it's like, if you have that bias, try to, as a student, try to get past it, because you'll find a lot more information than you ever would have if you're only sticking with the USA-centric approach to research. Because, we do kind of graduate thinking that, only our research is relevant, or maybe from, a random country in Europe, and that's the only things you can trust,
Well, I was taught that by a few faculty members.
That's terrible, because there's some amazingly smart people in other countries that aren't getting enough credit, in my opinion, especially in dentistry, because I read that a lot. But most of the things that I do read are not from the United States. Very few are. So,
and I would even just say, going through back, looking at the systematic review that I mentioned earlier, and it's a few paragraphs that mentioned the providone iodine. This particular one says several studies could not show significant differences between control solutions, sodium chloride, and other antibacterial agents, chlorhexidine and providone iodine, when used for subgingival irrigation during scaling and root planing. And it mentions that somewhere else down the way too. But a lot of those, when I go looking at the cited sources, are from the 80s.
Yeah, and there's so much more research since then. One thing about this study that I really like is, like I said, it was a double-blind study, which is what we're always going to go for, right? But they also use a Florida probe to calibrate across the board.
Yes, that's so important.
So there's very little variance in, operator technique here in actually coming up with these results.
Very nice. And, some of the people might be thinking, like, why is this an issue? Why are we getting kind of this, like, no significance between the two? I mean, you did see some pretty decent changes, but I wanted to just highlight some of the things that were in this document that I was reading for reasons that you might not see a change. And so one, they mentioned subgingival biofilm, which consists of adherent and floating bacteria, harbors more anaerobes than supergingival biofilm. That was one. Two, in periodontal pockets, it is more difficult for antibacterial agents to reach their target site and to sustain a concentration high enough to affect the biofilm, which is kind of where I was thinking maybe with the ozone.
Yeah, that's what
it's more technique sensitive. And I would even say back in the day when I did use things like Arrestin and Atrodox, like sometimes I'm like, the distal is number 18. I mean, fingers crossed I got it in there. I don't know though. Third, gingival crevicular fluid flow increases with clinical signs of inflammation and washes out antibacterial agents within a short period of time, thus limiting their subgingival effect, which I think we have had private discussions why like using chlorhexidine just seems kind of silly because it's going to flush out. I mean, probably by the time that they get up out of our chair, go check out at the front desk and get into their car, it flushes that quickly.
Yeah.
And then last, it said, in periodontal pockets, antibacterial agents can be inactivated by things like serum proteins. And that's especially true for chlorhexidine. Although chlorhexidine is currently the most efficient anti-plaque and anti-gingivitis agent available and is generally accepted as a gold standard, it has been shown to be inactivated by blood and serum. And, again, I think it was FDA is not approved for subgingival use. It's not actually FDA approved for perio, which is where I used it most of the time. It's more for gingivitis and for those times where you can't mechanically disrupt. So post-surgery or trauma, things like that, where you need to decrease inflammation, but you can't mechanically disrupt the biofilm.
Right.
Yeah. I think that we saw those results with the not being able to mechanically disrupt the biofilm, and we kind of ran with it like, if this is this great, super, then sub's going to be great also. I don't think we have the science to back that really yet.
No, not at all.
No, I would agree. And I think when it comes to subgingival irrigation, just for the students' benefit so they can kind of understand where we're coming from, I personally, again, don't use it on a regular. I can't even tell you the last time I used it. I have found really great results with subgingival biofilm management with my erythritol powder and also with home care and really getting the patient set up for proper home care management. And that's not just flossing. That's going to be very different for every person. And so that's where I have the most success with it. How about you guys?
I mean, they have to do, because they're seeing you, maybe 3-4 times a year at most. Yeah. And so 3 or 4 times a year, they're actually getting that biofilm disrupted subgingivally. No, it has to be done on a daily basis. I mean, home care is where it's at, period. If you can get their home care tweaked just right, then your job is easy.
Easy.
Yeah.
Easy.
Mm-hmm.
So I personally spend the time going through some very extensive home care instructions versus irrigating.
Yeah.
Yeah. I agree.
I do both.
Yeah.
Like
Well,
you're gonna listen to me while you have no choice because your mouth is open and I'm doing something to it, so you can't run away.
Yeah.
Do you get any staining issues with the Providone?
I've definitely ruined some shirts. I like to use syringe tips that have the little brush at the end. I don't know what they're called. I believe they're for endo usually, but it prevents dripping because the liquid will catch right at that little fuzz tip at the aperture of the syringe itself.
Oh, yeah.
Like the little micro brush.
Yeah, like a little micro brush for
Okay.
It
like at
prevents
the
it
end
from
of,
actually dripping down.
Yeah, it's at the end of the cannula
Mhm.
or whatever.
Yeah, exactly.
Yeah, okay, yeah.
Yeah.
But it's a really tiny version because you got to get it down into the pocket, correct?
Yeah. I have really small ones. Going back to chlorhexidine for a second, that's one of the biggest reasons why it just never seemed to work in the first place, because I learned in school that chlorhexidine isn't inactivated in the presence of serum. The only thing that makes chlorhexidine special is its substantivity. Listerine is probably just as potent, but it doesn't stick around. Chlorhexidine sticks to those tissues for 12 hours or so?
Yeah, it's
Something like that.
like
but
12.
But the serum, the crevicular flow, immediately deactivates that. So what are you really doing when you're flushing out a pocket that you just spent however long debriding, right? And that was one of the things I found about iodine, is that there actually was substantivity. It does resist being pushed out by serum and whatnot. And it has, I believe, it definitely wasn't in this article. It was one of the older ones from, I believe, Jorgensen Slots.
Mm-hmm.
He had studied that and found that it was still present a couple of months afterwards of applying it as well, which is what I was like, you know what, this is cheap. It seems to stick around. Why not do it? And I like to stress that I don't actually do this on all my SRP cases whatsoever. I would say maybe 1 out of 10. I save it for those people who have vertical bone loss, who have those really like sharp, hard to access deep pockets, really inky plaque that is just full of anaerobic bacteria. I don't use this for the close your eyes and you wake up and you're done with the kind of SRP case. This is for those really tough cases, aggressive perio, juveniles, whatnot, where I need to try and just kill that bacteria at all costs.
That's a good point. And I think also this really drives home how different each clinician can be. And it's going to be about your patient demographics. It's going to be about the tools that you have access to, and also the tools that you know how to use well.
Yes.
Just because you have it doesn't mean you are going to use it and be incredibly effective at
Mhm.
Yeah. And Daniel, because you're dealing with a large population of immune compromised patients, right?
Mm-hmm.
So definitely, that probably makes a difference too with making that decision.
Right. If somebody has a really low T cell count, their immune system is totally shot. Those everyday pathogens that they inhale can lead to, pneumonia, and that can kill them.
Mm-hmm.
Yeah. This is kind of off the subject, but kind of still on the subject because it's talking about chlorhexidine. But I was reading an article. It's a preprint, so it's not even been peer reviewed yet. But they were talking about how chlorhexidine kills HIV. And so do you use it as a pre-procedural rinse ever?
I don't see the point. I mean, HIV is not going to be transferring aerosol or anything.
I don't either. But I was just wondering if it was anything to it, because it basically
HIV is a very fragile virus. You could look at it hard and it'll die. So.
Yes. Well, the reason I bring it up is because it was in regard to COVID-19, as they were talking about that. And that virus is super, it's really fragile too. So they were saying how chlorhexidine should be effective if it's effective at, using it for HIV. So I don't know. That was kind of off the subject, but I was just curious about your take on it, how you thought about it.
I can see the logic behind like using a pre-procedural rinse or something to reduce whatever viral load might be in the mouth. But I mean, I think signs are pointing that this is really just an airborne virus, and that patient's still breathing right out their nose, right into your face. Like, there's no way you can prevent that. So it's like, we can give yourself like a little bit of a safety blanket if you want to feel better with the pre-procedural rinse, but what is it really doing?
Yeah. Oh, I agree 100%. I don't think that the pre-procedural rinse does anything for the COVID-19, but I was just curious if y'all utilized it at all because they were talking about how it was effective for HIV and I think Hep B too, they said. But like I said,
anything will kill it.
Right.
The only time I find myself using a pre-procedural rinse, I really have never seen the logic behind or why I should spend time waiting on it because I never saw it. But the time I do use them is I will use an alcohol-based Listerine on patients who are super heavy bleeders to kind of get that bleeding down as I'm starting and increase my field of visibility.
I agree. I think that's the only reason I would use it too. That's a good point. So I'm sorry.
Those people you just look at their gums and they start gushing blood. That rinse with an alcohol-based mouthwash really helps decrease that blood flow.
So sorry, I kind of veered off of the topic, but I had to ask that while I was thinking about it.
No, it's good. And I think also when you look at even CDC's recommendations, it just says there's no science to support it. And this was pre-COVID, but there's no science to support it. But there's also no science to say that it would harm. So why not use it if you want to use it? I think it also comes to like what your clinic looks like. Now, if it's like, moving chairs and stuff for a patient to get to the sink to do the rinse, I mean, I might just forego it. I would like to see in my clinic get to a point where not only are they're coming to my sink because I have two on their side, they're doing their 30-second pre-procedural rinse as they wash their hands.
Oh, that would be great.
And we just kind of knock out everything. So now they're touching my pens, they're touching whatever, the chairs, they didn't bring their germs too far into the practice. And then I would like to ask them to rinse or wash their hands as they leave. So if they did touch anything in my operatory, then they don't take it out of the clinic with them either. So we'll see if that actually is something I can get into that, what I would call my standard operating procedure.
That's a really good consideration.
Yeah.
It would be, man, just knock it out, right? Drive home
honestly,
the importance
pre-COVID, I wouldn't have really seen a reason to do that. But, somebody's coming in and maybe they're carrying and asymptomatic and they're touching their nose and face and everything. And on the way and they touch your doorknob, you touch this, they touch that. Why not have them wash their hands?
Well, I think if anything, and again, we digress in this away from subgingival irrigation, but I think it's also, when we look at the one thing that you could be doing to decrease infectious disease, it's washing your hands. So let's just wash our hands as much as often we can and promote that as healthcare providers. Do that in our clinic. You do it before, you do it on the way out. That's why it's super important, especially for your immunocompromised patients. But then I also get we got to balance it with living in a bubble, how clean it's. And I'm you'll get dirt from something somewhere along the way, I promise. But if you could just not have dirty hands that touches your face, that touches a pen that I then pick up, and let's just.
Yeah. You're getting plenty exposure to antigens constantly all the time. Every time you take a breath, you're exposed to stuff. So you're not gonna, by washing your hands, you're not gonna cause any issues. There's no way.
Exactly.
Right.
Yeah. So that's what I'm going to try to do in my particular public health clinic. And we'll see if I can implement that. Stay tuned.
Yeah. You'll have to let us know how that goes.
Yeah. So any parting words for our student-focused roundtable here on subgingival irrigation?
I stand with, I'm still not convinced that it's really effective enough to really do it. And I probably am not going to change anything that I do at this point with what I've read and what I know. If I do, it might probably be more with the iodine, since that was the only one that we got any real decent results from, but I'm still not convinced until I see a little more research on it.
I would say, you're going to find throughout your career that you have those patients that you just can't get it under control. And sometimes it's not even an issue of their hygiene. They have whatever factors, a genetic predisposition or severely aggressive bacteria, whatever, some kind of crazy biofilm culture that, you will come across that. And those are the times that you're going to have to think outside the box and try something different, if they can pay for Arrestin, as much as I'm a little iffy on Arrestin, but, if nothing else is working, and they're willing to do it, it might be worth a shot. Maybe that'll be the thing to kind of tip them over in the edge into health. Maybe that's what gets that bacteria under control for this person. So, see what is available to you, see what's out there, and use it for those patients that you otherwise just can't help.
And I would just say, if you are going into a practice that's charging out for subgingival irrigation, I would do some decent research on that, because we can, as we've seen in these 2 studies, and if you look at other studies, there's not a lot of strong evidence saying that it actually works. And so we are charging people for something that has very little research behind it. So I would be very cautious about that. But I think that we also can't deny that there are a lot of variables when we look at this research, especially when we look at perio and host response and systemic and diet, and just it goes on and on and on. So I would just encourage you, if you are graduating or if you're even a veteran hygienist that's been doing this for a while, keep up with the research, because it's evolving. And, we might be telling you right now that we don't see the evidence that, we're using it in our patient care, but maybe next year we come out, there's this amazing double-blind study and we're like, oh, wow, that changes it for me. And so just be willing, don't have like a belief bias around this. Just be open to the research, be skeptical when you're reading it, but also open to any changes. So,
yep. Science is definitely self-correcting. So we'll find out eventually if there's anything there.
Good. I like that. Well, thank you again for all of your expertise. I mean, we get yelled at anytime we're just hygienists. Like, you guys are way more than any just in the world. So thank you again for coming on and helping us learn and grow in evidence-based research.
Thank you.
Thank you.
We hope you guys enjoyed this roundtable. Thank you to our guests for bringing all their advice and the research that they found for us. And again, follow us on Instagram, follow us on Facebook. You can always go to our website, untitled2hygienist.com. We would love your feedback. And don't forget to share this episode and rate and review us on any of your listening apps.
Thanks, everyone.
Bye, y'all.